Yes, sir.
Take care, Ashish. Thank you.
Cholo, bye, sir. Bye, sir.
Thank you, Ashish.
Should I start sharing?
I would request all faculty to mute your mics if one of the speakers is talking. We can maintain the quorum.
Saurabh.
Yes, sir.
Now she will open the this Zoom arena for all the audience.
Sure, sir.
Below in the participants, you will start the count climbing.
Okay,
Once
sir.
to a decent number, then let us both of us decide and start it.
Okay, sir.
Another request I have to all the faculty here is that in the Q&A you will get questions from the audience.
Okay.
In case if you feel that you can answer them then and there, you can do that.
Okay.
And which you feel should be discussed by the whole faculty, those you can keep and then take them up at the end of the session.
Sure. Got it.
Mansi ji.
So the room is now open and we are audible and visible to the attendees. Yes, Dr.
Mansi ji, this code for quiz you just remember Z463. I have put it in chat box.
Chat box.
If
yes.
needed, keep it. Yeah. Okay.
Yes. Not a problem. So
Yeah.
this is going to be after the second talk, right?
Correct. Yeah.
After, yeah.
Okay. Thank you.
Right. Okay. Thank you.
Ashish, thank you. Mansi, after the second talk, just for
We show the Thursday flyer.
Yeah, so the Thursday thing, and then we'll proceed with the
Sure.
Savanoza sir's quiz. Great.
Yes, sir.
So, should I start sharing my screen, sir?
Yeah, you can.
Yes, you can start sharing your screen and you can keep your first slide on. And
This will stop others' screen sharing.
yes, you can say yes.
Okay, fine. So I hope my screen is visible. My voice is loud and clear.
Yes.
Okay. So at the outset, I would like to thank the fine organizing team for giving me an opportunity to present this not so easy topic. This is exosomes in stroke. So I'm Dr. Saurabh. I'm working as a neurologist in Artemis Hospital, Gurugram.
Just a minute, Dr. Bansal. Dr. Pujari, do we want to begin the session immediately or do we want to wait?
We have 23 participants. I think let's do one thing. Let's Saurabh wait until around 40 or so.
Okay.
35, 40.
For another 5 minutes.
Yeah, in another 5 minutes.
All right.
I'm not able to move my slides forward. आपने कुछ किया मानसी?
नहीं. You click on your slide.
Okay.
Now move ahead.
Fine, fair.
Yes.
Okay.
So you can keep the first slide on. And,
Okay.
Then you can begin probably at 8:40.
Sure, no issues.
Yeah, thank you.
On Tuesdays, literally everybody in my house is on Zoom. Children have classes. I am doing this, and Dipti also sometimes has this thing, webinar. Difficult, yeah. I think we have become here, we are just connecting through.
True, sir.
Virtually, I suppose.
Yes, sir.
Yeah, I feel, Sripa, now I think these webinars should reduce,
Yeah.
Because the workload has really started.
Too much.
Yeah, so and with your mask on, and in the clinic you have to keep talking. Now here you don't want to talk, you just want to listen.
Absolutely. No, and the Working is also not that pleasant, really.
Yeah.
With all that mask, 8 hours of mask, you go in COVID, you have to don and off. Horrible.
No, earlier when, in the first 3-4 months where the work was not so much, it was okay
Just
to
to
attend
enjoy.
so many webinars. I think, uh,
Absolutely.
you know, it becomes quite a bit, 2-3 webinars on the same day sometimes.
No, there is no
Everyone,
enough spare time in the first place
yeah. It's difficult.
to give.
We
Yeah.
had we had one, subsection meeting where only 12 people were there.
हमारा भी है.
13th came and went. He said, I don't want to be the extra player. So he left.
So
It
cricket
was a
team
good
बन गया.
meeting. Yeah.
Cricket team.
Yeah. I think we should start, because people will continue to join.
Yeah, I think.
Maybe,
Yeah, we are.
brief introduction and then we can start once again.
Absolutely. I think Saurabh had just left. We'll just let him come
Yeah,
back and then we'll start.
absolutely.
Now, let's hope now that we don't have more corona. Just a,
Is it,
just
I'm
people are
back.
expecting or suspecting, I would say, that the second wave might be there. One more surge might be there.
I'm just scared that I will be put to duty again. That's my fear. I'm living with a little bit fear anyway. So as Dr. Saurabh Bansal, good evening everybody. As Dr. Saurabh Bansal said to begin with, let's begin our today's evening tutorial session as usual. And this is the third session for stroke, in which, as you can see, I have chosen 2 lectures and a quiz. Obviously, the quiz really takes you through many topics in just more than 40 minutes. It has its own advantages. And in the 2 lectures, one of them I have chosen a very odd topic displayed here in front of you. You should be aware of these googlies, I must say, as they may appear once in a while in the basic science session. And the second, management, clinical features and management of SH, is the standard one, which also you need to revise. And Dr. Balakrishnan will do that for you. To begin with, I hand over to Dr. Saurabh Bansal.
Thank you, sir. First, at the outset, I would like to thank the fine organizing team for giving me this opportunity to present this not so easy topic. So I'm Dr. Saurabh. I'm working as a neurologist at Artemis Hospital, Gurugram. So when Dr. Shripad contacted me, ki you have to speak on this topic, I said, sir, I've never heard this talk. I've never heard this word before. So I didn't know how to approach this. So once in a while, we may come across this question during exams. No matter how hard we prepare, it's very difficult to deal with such questions if you're not aware. So my job is to make this topic easy, just to give you a brief overview of this topic so that we are well aware of this. So when I did the search of exosomes and stroke, to my surprise, there were about 314,000 results within less than 0.4 seconds. So I was like, oh, it's not that uncommon. So what are exosomes? Why exosomes are of interest? Exosome biogenesis and content. What is basics of endocytosis? Exosomes isolation and storage, interaction with target cells, their role in stroke. What are their advantages and conclusions? So I'll try to cover all this in next 15 minutes. So exosomes are nano-sized vesicles within 30 to 100 nanometer in diameter. They target the cell function by delivering proteins, lipids, and nucleic acids. They play essential role in intercellular communication by transferring their cargo. By cargo means their content like protein, lipids, and nucleic acid to the target cells under physiological and pathophysiological conditions. So there are different types of extracellular vesicles depending on the size. So exosomes are 20 to 100 nanometers, microvesicles are 50 to 1000, and apoptotic bodies are 500 to 2000. So our area of interest is today exosomes. So their size, as we have discussed, is 20 to 100 nanometers. Biogenesis, which we'll be covering in subsequent slides, they are generated through endolysosomal pathway. For that, we need to know a little bit about endocytosis that I'll be covering. Their compositions, they contain that lipids, aminophospholipid, their content, RNAs, microRNAs, DNAs, proteins, and their biomarkers. So why all of a sudden there is so much interest in exosomes? So They are secreted by any cell type and can be detected in body fluids, including blood plasma. They are key mediators of intercellular communication. Hence, they participate in normal physiological processes. They can be used for therapeutic approaches such as immunotherapy and delivery of pharmacological agents or genes. They have a potential as a biomarker for cancer and neurodegenerative diseases. So, as we know, they originate from endolysosomal pathway and they are formed by inward budding of the membrane. So to make things easier, so what is endocytosis? It's a cellular process by which substances are brought into the cells. So this solid particle is brought into the cell body by invagination of the plasma membrane, and hence it forms a vacuole. So the material to be internalized is surrounded by an area of cell membrane, which then buds off inside to form a vesicle containing the ingested material. So the endocytic pathway consists of different membrane compartments. So the early endosomes and recycling endosomes, they internalize the molecule from the plasma membrane and recycle them back to the surface as extracellular vesicles. So these extracellular vesicles, depending on their size, are the exosomes. Similarly, invagination of the plasma membrane, they take up the material, they form the early endosomes, they form the microvesicular bodies, they contain the DNAs, RNAs, proteins, and then they keep them into the extracellular space. And these of 50 to 100 nanometer size are the exosomes, and then they target their cells of interest and they enter the bloodstream. So their membranes are enriched with cholesterol, sphingomyelin, ceramide. As we know, they contain biologically active molecules such as proteins, RNAs, DNAs, lipids. So these molecules mediate exosomal intercellular communication and they target specific cell types. So they modify their target cell's function by delivering proteins, lipids, and nucleic acids. So this is extracellular space. These are the extravesicular bodies, depending on the size. Microvesicles with this light blue shade, apoptotic bodies. So these exosomes, if you see their structures, they consist of bilipid layers. The content is of the DNAs, RNAs, and the proteins. And these some proteins, they're abundant in nanoparticles. They can be as exosome markers like heat shock proteins, tetraspanins, etc. So this is in short the summary of their formation, their content: endocytosis, early endosomes, late endosomes, microvesicular body formation, then they come out into the extracellular space. And this is the content of the exosomes containing DNA, RNA, microRNA. They have importance in signaling proteins, membrane trafficking, heat shock, death receptors, and various other growth factors and ribosomal proteins. So many functional effects of exosomes may be attributed to the transfer of their RNAs and microRNA. They are the most relevant cargo in exosomes, and they influence several proteins and enzymes within one or more cellular pathways in the target cells. They participate in antigen presentation, cell adhesions, cell structure and motility, and are stress regulators involved in transcription and protein synthesis. So what is the way of isolation and storage? There is to date no gold standard method for exosome isolation, which complicates their inter-laboratory comparisons. Ultracentrifugation is considered to be one of the most sensitive, but still there is no gold standard method. Exosomes are stable at 4 degrees for short term, that is about 7 days. And then where they are stored at minus 80 degrees, they can be stable for about 90 days. Storage below 70 degrees, most favorable condition for long-term preservation. So as we know, they have a role in intercellular communication and transferring their cargoes, that is the protein, lipids, microRNAs. So they are taken up by the target cells by various mechanisms, most of which are mediated by endocytosis, that we know the cellular process of taking up the particle into the cell. They can be either through clathrin mediated, phagocytosis, lipid raft mediated, as well as micropinocytosis, that is nothing but the water intake. Exosomes bind to the target cells via ligand receptors such as the integrins, tetraspasins, or the intercellular adhesion molecules. So biogenesis of extravesicular bodies and their interaction. So these are the exosomes which are into the extracellular space. They are attached to the target cell via antigen presentation, cell signaling, phagocytosis, MHC recognition. They enter the target cells and they deliver their content of interest, microRNAs, proteins, the antigens. So exosomes and stroke. So the treatment of stroke and neural injury with extravascular bodies that are exosomes, they are harvested from the mesenchymal stromal cells or the stem cells, rather than the exosome from the parent MSC, because the benefit of administration of parent MSC is not that much as compared from the extra source. Exosomes are internalized by recipient cells, which avoids a multiplicity of potential concerns associated with administration of living cells. Hence, they provide therapeutic benefit, at least equivalent of their cellular source. So what are MSCs? Mesenchymal stem cells, or they are also called as stromal cells. They are multipotent cells that can differentiate into variety of cell types, as we can see into the bone cells. They can be into fat adipocytes, myocytes, myocardium, hepatocytes, various cartilages, etc. So how exosomes help in stroke? So when intravenous administration of exosomes have the tendency to pass the blood-brain barrier. So they're taken up by the brain cells. As we know, their content having RNAs, DNAs, microRNAs, they interact with the cells and they transfer their content via endocytosis or various ligand receptor interactions. They communicate with the brain cells, they induce neurogenesis, induce white matter axonal and vascular remodeling, thereby inhibiting neuroinflammation and promoting neuroprotective as well as restorative effects, and overall improving the functional outcome after stroke. So this is the in short summary how therapeutic effects of exosomes are in stroke. This is a pictorial image. These are the cells, microvesicular bodies into the extracellular space. They are the extravesicular bodies. They are isolated, purified, injected intravenously into the rat. They have the tendency to cross the blood-brain barrier. This is the structure of the exosome, containing various receptors, nucleic acids, proteins, lipids. They interact with the target cells either through antigen presentation, cell signaling. They enter into that and thereby promoting neurogenesis, white matter and axonal remodeling, vascular remodeling, decreases neuroinflammation, in short, overall providing neuroprotection, neurorestoration, and hence the better functional outcome. So how does it help in angiogenesis and neurogenesis? So the mesenchymal stem cell derived exosomes, they promote functional recovery by inducing angiogenesis and neurogenesis. For that, we need to know microRNA 132 serves as an intercellular signal, which is a new approach for neurovascular communication. So stem cells communicate with the brain cells, modulate growth factor via microRNA 133b through exosomes. They regulate transfer of microRNA 133b into astrocytes and hence modulate gene expression and promote neurite remodeling and functional restoration. For this, we need to know there are two important microRNAs. One is microRNA 132, which is for neurovascular communication, and microRNA 133b, which is for neurite remodeling and functional restoration. So hence, MSC-derived exosomes could improve diseases by delivering functional biomolecules to target cells. Another picture to make things easy, exosome-induced neurorestorative effects after stroke. So these are the mesenchymal stem cells or the human umbilical cord blood cells. There are exosomes from this. In the astrocytes, they decrease inflammation, improve remodeling. In the microglia, macrophages, anti-inflammatory cytokines, improves the synaptogenesis. Neurons, decreases the apoptosis, increases white matter remodeling, improves neurogenesis. When they cross the blood-brain barrier and the vessels, improve the permeability of the blood-brain barrier, improve vessel stabilization. So effects of extravesicular cells or exosomes and the brain cells. So astrocyte-derived extravesicular bodies, they transport compounds involved in neuroprotection, regulate synaptic transmission. MSC-derived extra EVs contribute to tissue repair, increase axonal density, improves the neuroblast number, induces neurite remodeling. Microglia derived EVs spread inflammatory reactions, modulate synaptic activity. So in short, it affects all the cells. All the cells can make it, and thereby, depending which cell is generating, there will be different effects of it. So what are the advantages of exosomes? They have low immunogenicity, good innate stability, high delivery efficiency. There is no risk of vascular blockage. They have the ability to pass through blood-brain barrier. They enter the brain parenchyma, have the potential to be therapeutic delivery carriers to transmit specific molecules, promising role as biomarkers, potential to develop large-scale cellular factories of engineered therapeutic vesicles. Less toxic biodegradability is there. They are extracted from bone marrow MSCs. They have good anti-inflammatory and neuroprotective effects. They're ideal biological agents for treatment of nerve and neurodegenerative disease. So, but there is one caveat to it, is that the exosomes lack target ability, limiting its clinical application. This limitation needs to be resolved in future studies. So the exosomes are isolated from different cell types. They are rich in RNAs, microRNAs, and proteins. Different cell types, we can get the exosomes. The exosomes can serve as efficient carrier system to deliver different pharmacological molecules to different target cells, as we have seen. These molecules can be further modified and reinserted into the exosomes for different therapeutic applications. They can be like carrier vesicles. They can do for gene therapy, the protein delivery. So what are the paracrine effects exerted by exosomes from various cell sources? So embryonic stem cell derived exosomes, they have importance in transmitting bioactive molecules, including growth factors. Endothelial progenitor cells derived exosomes, they deliver microRNA coding for angiogenesis. Mastocytes derived exosomes, they have functional RNAs, microRNAs among them. MSC derived exosomes that we have seen, they have importance in transferring DNA, proteins, microRNAs, RNAs, lipids to the target cells, and importance in intercellular communication, and specifically in stroke, as we have seen, angiogenesis, decreasing the inflammation, neurite growth, etc. So the research on exosomes and relevant extracellular vesicles is a promising and expanding field for the treatment of brain diseases and as biomarkers of disease condition. Targeted microRNA transportation for the promotion of neurogenesis shows promise for improve the prognosis following ischemia, as we have seen specific microRNA 133 and 132b. So in a word, if you have to see, exosomes have a great potential when it comes to alleviating brain injury following stroke. Thus, they provide beneficial effects for stroke patients, which is worthy of further investigations. So these, though I had referred many articles, but these were the two main articles which will help you in better understanding, and most of the references were taken from this: the role of exosomes in stroke and the exosome therapy for stroke. Thank you for your attention.
Very nice, Dr. Bansal. See, as we can see, such a thorough presentation planned in the first slide with specific points and then delivered with a lot of diagrams and a few flow charts. So make sure that you use that. It's a difficult area, very difficult area really. It's done very well with it.
Thank you, sir.
On to now a more real life day-to-day practice scenario, which is on SH by Dr. Balakrishnan. And I request Dr. Balakrishnan to share his screen and begin his lecture.
I hope I'm audible and my slides are clear.
Yes.
Thank everyone for giving me this opportunity from the panel board. I'm Dr. Shankar Balakrishnan. I'm an interventional neurologist, and I'm going to talk about the management of subarachnoid hemorrhage. And ETH is the university where I was trained for intervention neurology, and I would say it would be the birthplace for intervention neurology. And you see the definition of subarachnoid hemorrhage. Remember, when the blood collects in between the subarachnoid space and where the CSF flows. The cause could be traumatic and non-traumatic. That's how it's classified. And now in this talk, we are going to see in detail about aneurysmal subarachnoid hemorrhage. The most common cause for a subarachnoid hemorrhage would be again an aneurysmal rupture. There are many other causes which falls in this list, and we are the neurologists are the one who needs to diagnose the subarachnoid hemorrhage and then give it in the hands of interventional neurologist. The purpose of my talks is for the fellow PGs to write as an essay or a short notes in their exams, and also to motivate them to take up the field of intervention neurology, which is going to be the future. Aneurysmal rupture constitutes 80 to 85 percentage, but even then, it's our responsibility to diagnose other conditions or other causes for SAH. The AVM or fistula, though we don't come across very often, it should be in our mind. And even CVT is associated with SAH. We should not miss a treatable condition like CVT. And vasculitis, a major bleeding within an unusual site. And always don't forget coagulopathy, and always go through the checklist of drugs and toxins causing SAH. Looking at the pathophysiology, when the blood extravasates into the subarachnoid space, it quickly spreads through the CSF around the brain and the spinal cord. So this causes a direct damage to the local tissues. It increases the intracranial pressure and it causes meningeal irritation. And another school of thought about the pathophysiology is it is not the blood which is spilled into the arachnoid space. It is the perianeurysmal environment which plays a role in the pathophysiology. The vessels of the brain are completely different from the vessels of the other organs. They are very sensitive and they are extremely supplied by sympathetics. So when the blood products enters into them, the blood vessel wall reacts to the inflammation that is created. And most vasospasm do occur not only because of the blood product, it is also the sympathetic system in the vessel that reacts to it. And risk factors for prevention of SAH is bring down hypertension, the lifestyle modification, and it is more predominant in female sex. And in the presence of an unruptured cerebral aneurysms, we have to be very cautious. Family history of aneurysm, don't miss it. Always screen the family members if you find an unusual aneurysm of bigger sizes. And the SAH increased risk of rupture is seen during pregnancy, delivery, and the puerperium. So when we stratify the risk factors, it is also always important in prevention rather than treating a subarachnoid hemorrhage. The easy ways to prevent a subarachnoid hemorrhage, first is the blood pressure. So it is a class 1 evidence says that the control of blood pressure with antihypertensive will always prevent ischemic stroke or intracerebral hemorrhage. And level B evidence is therefore, like if you control hypertension, then there is a reduced risk of subarachnoid hemorrhage. And when we follow the patients, we always advise them to go for lifestyle modification like quitting alcohol and tobacco is also important because aneurysm can reoccur in another site. And after any aneurysmal repair, we need to do a follow-up images, and also the family member should undergo a scan. Looking at the natural history and outcome of an SAH, mortality varies from 8% to 67%. Most of them, before reaching the hospitals, they die of huge hematoma and sudden death can also happen. But when they reach the hospital, we need to assess what are all the risk factors. From the ER is the point, the treatment or the management of an subarachnoid hemorrhage starts in the emergency itself. So looking at the factors like old age and any pre-existing medical illness, or there is a cerebral edema on the CT, and if you see a large hematoma or an intraventricular hemorrhage, and in the presence of vasospasm, or when we come across delayed cerebral infarction, then other cofactors like fever, anemia, hyperglycemia is going to influence it. And in post-op, commonly pneumonia and sepsis, and sometimes myocardial infarction can also happen in these patients. And they are also more prone for developing pulmonary embolism. So clinical presentation, 97% of the patients presents with headache, where they classically describe thunderclap headache. And sometimes there can be warning signs like sentinel hemorrhage, which can happen in 43% of the patients. And minor leaks like due to AVM may not be reduced. And sometimes if there is a major sudden loss of consciousness, and meningism is one factor which should always look for in a patient with a sudden onset of headache. Most of the time it will be misleaded as migraine, but keep that if you find a meningism in a migraine or any other headaches, you should rule out an subarachnoid hemorrhage. Other common signs we won't usually miss, but meningeal irritation, another one more important sign is look into the fundus, and if you see a perihyaloid hemorrhage called Trisson syndrome, then you should be very cautious that it could be an MC aneurysm causing this thing. And clinical presentation is predominantly due to a meningeal irritation, which is reported as 75% of the cases can have meningeal irritation. Usually takes 6 to 24 hours to develop. And other signs like other presentations. Even patients can present with coma due to raised ICP. Sometimes there can be a massive intracerebral hemorrhage also, and seizures and low cerebral blood flow can cause. Focal neurological signs which gives us clue is ocular hemorrhage, that's what we call as Freezer syndrome. Sometimes they present with fever and sometimes present with meningitis like picture also. So when we findings, so when what as a clinician, what are all the clinical signs that we need to see is like in many mental changes can happen with any aneurysm, any location, and the meningism is common. If you see that it takes 3 hours to 12 hours to develop, but look for meningism always. And third nerve palsy is very classic for a post-PCOM aneurysm, and the 90% of the patients with third nerve palsy due to aneurysms compared with other causes always think about a PCOM aneurysm. And sixth nerve palsy happens due to increased intracranial pressure, and it indirectly indicates a high clot burden, and it gradually resolves when you treat it. And sometimes ACOM aneurysm present with bilateral weakness in legs, and ebulia is a very, like, even we tend to miss ebulia in patients with ACOM aneurysm when they present. And posterior circulation stroke predominantly present with nystagmus, ataxia, and dizziness, and MCA territory aneurysm present with hemiparesis, aphasia, and neglect. And what is called as Strizzen syndrome is it's seen in 10%. But if you see a subhyaloid hemorrhage in fundus, then it indicates a poor outcome. Grading system for aneurysm is very important, and from the theoretical point, you need to write at least 4 grading systems. Since it is fixed and there's no change, I'm just passing through the science for the want of time. Hunt and Hess grading system is very important, and this, like, mostly like neurosurgeons will be very well versed with Hunt and Hess grading system. They apply very frequently, but a neurologist should also know as other grading system like WFNS systems, which takes predominantly GCS and motor deficits, and modified Fisher, that's called class and subarachnoid hemorrhage CT rating scale. It takes into the thickness of the SAH is an important factor, and also it takes into account the intraventricular hemorrhage, also into a factor. And the newer grading systems actually takes all other grading systems and gives us a points which grades from 0 to 5 also should be applied in taking. And the first investigation modality for any patient with subarachnoid hemorrhage is a CT brain plane. So it will give us a lot of information when we look at the predominant thickness of subarachnoid bleed in the Sylvian fissure, mostly can be from ICA, MCO, or PCOM aneurysm. But if you see a subarachnoid hemorrhage in the intrahemispheric fissure, most likely to be an ACOM rupture. And if you see a ventricular, third ventricular, or fourth ventricular, intraventricular hemorrhage extension, then it could be a pica or a vertebral artery aneurysm ruptures. And even if you don't see a subarachnoid hemorrhage, and even if you still clinically suspect a subarachnoid hemorrhage or aneurysmal rupture, do a lumbar puncture, which will give us a lot of information. And actually it takes xanthochromia to 12 hours to 2 weeks, it will be positive. And as the time evolves, the xanthochromia gradually resolves, but at least it is positive 70% in the first 3 weeks, and in following weeks it gradually gets decay. And it is not just a macroscopic appearance of the CSF. Always send it for a spectrophotometry, and usually the RBC count will be more than 1 lakh, and high protein level will also be seen due to breakdown of proteins. Cerebral angiography, cerebral DSA, is a gold standard for evaluation of cerebral aneurysm. It's very sensitive, and it's also useful not only for diagnostic purpose, but it gives lot of information for you in treating the aneurysm. Either the aneurysm should be subjected for coiling or a clipping, but it will give additional information for the surgeons also when they operate. Not only the size, shape, and orientation, it also gives a lot of information about the parent artery, and any perforating arteries arising from the dome is also very important. And sometimes we will think about one aneurysm, and sometimes there can be mirror aneurysms or multiple aneurysms. Cerebral DSA, when we do a selective angiography, it gives a lot of information about the aneurysm and the primary pathology of vessels also we can see. Most of the time, vasculopathy associated with multiple aneurysms. So we should not be having a narrow window. Cerebral DSA helps in identifying multiple aneurysms. And if cerebral angiography findings are negative, and definitely we should do a repeat angiography in 3 weeks time. That will help in identifying, because once it ruptures, it goes for a vasospasm, it goes for vasospasm, or you may miss a blister aneurysm. So it's definitely strongly recommended to do a follow-up angiography after 21 days. MR angiography, it's limited, but it has its role. Like if a family members or a first degree relative of a patient who has a huge ICA aneurysm and they want a screening, we don't need to subject them for an invasive cerebral angiography. MR angiography can be used as a screening tool, and also it is useful in is useful when you see adjacent aneurysm. You can see how much intramural thrombus is there, and it's sensitive, but it can detect more than 3 mm aneurysm. And one modality which we are recently started doing in MR angiography is a vessel wall imaging. Actually, vessel wall imaging gives a lot of information about the aneurysm. The aneurysm doesn't rupture because of its size or because of its flow. It's actually the inflamed vessel is a most important factor in predicting whether an aneurysm will rupture or not. So MR vessel wall imaging plays an important role in the workup of subarachnoid hemorrhage. And when we talk about management, there are multiple factors, and this within 15 minutes is very difficult to talk about in depth and in detail about each steps of management. But when it is asked as an essay question or short notes, this is the region that you can expand and shrink. So when they ask us a short notes, try to write few points on each topic. That is most like 16 conditions that we need to address. And the most important point is about risk, like preventing a rebleed. So rebleeding is the most disastrous and disabling situation. It can lead to mortality up to 70%. So it is a clicking time bomb in the brain, and the risk of re-rupture is very high during the first 24 hours, and the percentage actually falls a little, like 1 to 2% for the next 2 weeks, and 30% rebleed by 30 days, and 50% rebleed by 6 months, and then thereafter it actually increases by 3%. And when you see a high grade Hunt and his scale, it indicates that the rebleeding risk is literally high, and we should initiate measures to prevent rebleeding at the earliest possible, and in aneurysmal repair when possible and reasonable go for, and an immediate good control of blood pressure is also mandatory. Keep a modest level of like mean of 85 to 110 is sufficient. And definite treatment is microsurgical clipping or endovascular coiling, and the goal of treatment is complete obliteration of aneurysm. Any aneurysm can be clipped and any aneurysm can be coiled. So it is like both the fields or have its own positive and negative things, but both the fields should evolve, and both should not, like clipping should not prevent coiling, or it's an emergency field, and the skills should not be lost. The surgeons should not give away clipping, and as a neurologist we should take up intervention radiology, and we should learn how to coil an aneurysm, and we should capture this field again back to us. So the definite treatment, whenever you feel the direct straightforward is for coiling. And you say it's an easy technique, like when we do under GA for small neck aneurysm, it's easy to take and put a coil inside, it doesn't get out. And one of the things is the neck to dome ratio. If the neck is wider, then there is a chance that the coil can migrate later on, but with the help of a balloon or a stent assisted coiling, then we can do it with a better way. And so that's why I talk about any aneurysm can be coiled. And clipping, when there is a difficult scenario, like if it is highly looped and very difficult to take the catheter close to the aneurysm, then we can offer them a clipping. And another situation is if there is a huge hematoma, like in MC aneurysm, there is a huge hematoma which is causing a midline shift. Definitely, even if you coil, the patient may need decompressive craniotomy, and we need to evacuate the clot. So such situations, when they go for craniotomy, they can evacuate the ICH, as well as they can clip the aneurysm in the same setting. So in Zurich, the preference is if there is an MC aneurysm, mostly it will be given to the surgeon for clipping. And when the surgical situations like basilar artery or elderly age with poor grade, they come for coiling, where surgical morbidity will be definitely less than clipping. And in again situations like wide neck or multiple blebs, or if the geometry is complex and if a main branch is arising, or when you see a giant aneurysm with a partial thrombosis rate, and sometimes if it is very difficult to navigate the delivery system, then you can offer clipping. But in all these situations, it's subjected to a multidisciplinary approach A board should be established where a neurologist or an intervention neurologist and a neurosurgeon and a skull-based surgeon should be there to discuss, come up with a unique decision which is best for the scenario, and then we have to offer the treatment. So as I said, if you see a large aneurysm, sometimes you will be seeing from the dome an important vessel may be arising. In these situations, coiling is little difficult, not possible. It's not impossible. It's little difficult. The vessels are at risk. So in these situations, what we do is flow diverters. The flow diverters, we can't use it in an acutely ruptured one because we need to use antiplatelets to stabilize the flow diverters. Actually, what a flow diverter does is it diverts the flow away from the aneurysm, and whenever there is a stasis happens inside the aneurysm, it goes for a chronic thrombosis, and then the endothelialization do happen, and this is complete endothelialization do happen with flow diverters. And if any branching vessel is there, it gives a way for the blood flow to happen through the branching vessel. So it can be used whenever there's a big aneurysm. Just put a flow diverter and fill some coils to enhance thrombosis inside the aneurysm. And this, with the advent of flow diverters, now we are able to treat even large aneurysm with an important vessel arising from the dome. Flow diverter plus few coils inside the aneurysm will help in treating these patients. And when you go for clipping skull base, you will have a very little access. Say for a tip of basilar, it's very difficult. But an MCA is an easy approach, and when they cut open the sylvian, they can see the MCA bifurcation directly. But top of basilar aneurysms are very difficult to clip, and most of the time it tend to rupture, and it creates a lot of trouble. So in those scenarios where the neck is wide, like here, the neck is very wide, even if you put a coil, it tends to slip into the parent vessel and it causes obstruction or immediate occlusion can happen on the table. In those scenarios, we use a stent, and then we take the catheter, and through the stent, we can deploy a coil, and stent assisted or sometimes balloon assisted coiling will help in wide neck or wide based aneurysm. And after treating this, vasospasm is another important field. Even if an intervention neurologist does coiling, vasospasm starts and it slowly starts picking up. We need to monitor, like just securing the aneurysm is not sufficient. Vasospasm should be taken care. And the best tool to find or to track vasospasm is your transcranial Doppler, and it can predict before like 48 or 2 days before your clinical signs develop. And always look for the flow velocity. Flow velocity is a very good indicator. Cutoff is, we keep a cutoff of 100 to 120, and if it is exceeding above 150, you should be very cautious. And if it's above 200, it's a severe vasospasms. Your oral nimodipine or will not help in such scenarios. We need to take up the patients for intraarterial spasmolysis. As you see here, the spasm is very severe. The grade of vasospasm is severe. Once we put a catheter here and we give intraarterial nimodipine, it slowly opens up. You can see the extent of vasospasm in the M1 branch, and it opens up completely on the table with the help of infusion. So use transcranial Doppler, develop your skills in, this is a very good area where the neurologist can learn transcranial Doppler, and it will be very useful to monitor the patients. And strategies to prevent vasospasm is multiple strategies, but the best is triple H therapy, which prevents reversible ischemia, and sometimes we need to use papaverine, milrinone, and if it is too much refractory and not responding to any of the medications or intraarterial nimodipine, go for a transluminal balloon angioplasty. That will definitely help the patients from getting out. And nitroprusides are still experimental, but milrinone works. Most of them use milrinone along with nimodipine. And vasospasm management protocol, every institute should set up their own protocols in following up patients with subarachnoid hemorrhage. Even they undergo clipping or even when they undergo coiling, the post-op management, we should not lose the patient due to vasospasm. And triple H therapy, it's again like on the one side we need to induce hypertension, on the other side we need to keep them hypertension under control with nimodipine. So it's a balance between induced hypertension and a control of blood pressure. So it's actually a trick, and we need to keep both in mind and then treat the patients. And there is a lot of complications are also associated with the triple H therapy. And we should not miss other differential diagnosis for SAH. So it could be a non-aneurysmal, it could be a pseudo subarachnoid hemorrhage, and sometimes RCVS can confuse as with aneurysm. And I thank for this opportunity. This is Miyot International where I work, and few centers only promote neurologists into the field of interventional radiology, and Miyot is one center for this opportunity. I thank everyone.
Thank you, Dr. Balkrishnan. See, very thorough again. See, you should understand when you're using all investigative and management modalities, you should be able to remember a few sensitivities of the investigations, and you should be able to compare treatment modalities like he did with clipping as well as coiling, the and which aneurysms, which modality of therapy usually is preferred. I think with that, I request Manasi to show our Thursday slide, wherein this Thursday we have assessment, evaluation of aphasia by Dr. Pauranik, who is, has specialized in aphasia and has worked for more than now 10-15 years. So please take benefit of this Thursday session. And now with this, we move on to the last part, which is the most exciting, that is the quiz. This time we have Dr. Pawan Oza, our professor from JJ Hospital, to conduct quiz on all the sessions that we heard on stroke. So off to Dr. Oza.
Thank you, Dr. Sripat Pujari and Dr. Kothari, for allowing me to conduct this quiz. And it is more like a summary of contribution of all the previous speakers in this session on stroke. Let me directly take you to the quiz. I'll start sharing the screen.
It's just while Dr. Oza is sharing, the code on Slido today is Z463.
Yeah,
As you can see, it is displayed. It's there on the chat box as well.
Yes. So let me begin the quiz by this one question. So which biomarker does not indicate 1 minute? Give me a minute, please. Sorry, there was some problem with the power. Yes. So which biomarker does not indicate? Am I audible? The golden question.
Yes.
Yeah.
Yes.
Thank you so much. It's customary to ask this question. Which biomarker does not indicate aspirin resistance? The four options are P2Y12 platelet function test, PFA 100 test, modified thromboelastograph, or rapid platelet function analyzer system. You will get 15 seconds for this, and you have the code here. Please join the quiz. The code is 463, and these are the four options, and you get 15 seconds for that. So P2Y12, PFA 100, modified thromboelastograph, or rapid platelet function. Which one does not indicate aspirin resistance? Right. So we got many people to vote for it. 12 people voted, and the correct answer is P2Y12 platelet function test. It is a test for clopidogrel resistance and not aspirin resistance. We'll see who leads the vote later. Let's go with the second question. Now we all know MMP9. What is not true about MMP9? It predicts hemorrhagic transformation after IV thrombolysis. The MMP9 pre-treatment level correlates with the degree of hemorrhagic transformation. It cannot predict hemorrhagic transformation in those patients who have not received the thrombolysis, the IVT. And fourth, the high levels of MMP9 are associated with atrial fibrillation. Which one is not true? So please get ready. And your time starts now. What is not true about MMP9? This is going to be interesting. Let us see. Right. So many of you got it, and the correct answer is that it does predict even in those patients who have not been thrombolized. So hemorrhagic transfer, because it is related with the breach in blood-brain barrier, right? So the next question is another one from biomarkers. Which biomarker is elevated in large artery atherosclerotic stroke? MMP9, SB100, copeptin, and LPPLA2 activity. Get ready, guys. And your time starts now. Which is elevated in large artery atherosclerotic stroke? MMP9, SB100, copeptin, and LPPLA2 activity. Right. So we have almost everyone. Great. Right. So LPPLA2 is associated with atherosclerosis, coronary artery disease, and stroke, whereas as we saw, MMP9 is associated with hemorrhagic transformation, SB100 with malignant edema, and copeptin is associated with poor prognosis in strokes. But this is under evaluation, and it will help us in the future. Now again back to exosomes. So you all are going to crack this now. What are exosomes? Are they intracellular vesicles? Are they extracellular vesicles? Are a type of mitochondrial body? Or is it a lysosomal apparatus? Right. Get ready to vote. So your time starts now. Exosomes, I will give you a hint that I'm not going to help you this time, but you had a talk this time. So intracellular vesicle, extracellular vesicle, and let us see who got it right. So almost everyone got it right, and it is a type of an extracellular vesicle. Other types are being apoptotic and microvesicles. The size is less than 100, and this last line is very important. These are key regulators in cell to cell communication. You want the cells to talk to each other, right? Next question. The therapeutic effects of exosomes in stroke is by inducing neurogenesis, inhibiting neuroinflammation, vascular remodeling, promoting white matter or axonal remodeling, or all of the above. Let us see. Right. Is everyone ready? So the therapeutic effects of exosomes in stroke is by which of the following mechanisms? It'll be easy to guess. Yes. Great. Let us see. So it's so obvious, yes. But I'm sure there are people out there who think the other way. Always, yes. So the right answer is all of the above are the mechanisms. Right. So this is the various mechanisms. So the interesting thing to note is that these exosomes, they pass through blood-brain barrier and then they get on the target cells, and these are the various mechanisms. Right. So the next question is on a different realm. Which CT perfusion parameter is not consistent with ischemic penumbra? So this is a tricky question. We all know the answer, but this is a tricky question. So the CT parameter which is not associated, prolonged MTT, prolonged Tmax, reduced cerebral blood flow, reduced cerebral blood volume. Which one of this? Right. So here you go. Which CT parameter is not consistent with ischemic penumbra? Prolonged MTT, prolonged Tmax, reduced cerebral blood flow, reduced cerebral blood volume. Right. Let's see who got it right. Everyone got it right. Yes, everyone. Still, there are some people out there. Yes. Let us see. Next one. So the answer is that obviously reduced cerebral blood volume is only seen in infarct and not in penumbra, whereas the blood flow is reduced both in penumbra as well as in core. Next question. In the ischemic cascade, which receptors are involved in excitotoxicity? This is listen carefully. So inotropic receptors like NMDA, AMPA, kainate, or metabotropic receptors, both type of receptors or none. Shoot. In the ischemic cascade, which receptors are involved in excitotoxicity? Inotropic, metabotropic, both or none? Right. So the inotropic receptor, as we saw, this is the right answer. So since the problem is with the failure of the cells to maintain ionic gradients across the membrane, which leads to depolarization, here there is no job of the metabotropic receptors. So that's why the inotropic receptors, which are the NMDA, AMPA, and kainate in the glutamatergic pathways. So that is the right answer. Let's go for the next one. Which effect of calcium influx is not related to protein misfolding? Now this is not a great quiz question, but just to wake you up. So endoplasmic reticulum, Sarka pump failure, halting new protein synthesis, chaperone misfunctioning, or mitochondrial swelling and damage. Which effect is not related to protein misfolding? Get ready, guys. Yeah. So here we are, all the four options not related to protein misfolding. If you are awake, you will pick it up 100%. Great. Let's see. Yes. So almost everyone is awake. And the thing is, the clue is that mitochondria are not involved in protein synthesis. So excess calcium accumulation in mitochondria causes dysfunction, swelling, and membrane collapse, but it's not involved in protein synthesis. Chaperones, they guide protein synthesis, and Sarka pump failure is involving the halting of protein synthesis. Right, next one. Next question. White matter is more susceptible to ischemia than gray matter. This everyone knows. What is not true about this? So white matter receives less blood supply than gray matter. Glial cells are easily damaged by glutamate toxicity. Ischemic injury to oligodendrocytes causes more functional deficits, and NMDA receptor toxicity is the major cause of white matter injury. These are the four options. We'll have these options once again. Right. White matter is more susceptible. What is not true about this out of these four? Right, the time is up. Let's see the results. So we have about 38% who say that NMDA receptor mediated toxicity is major cause. This is not true because that is the limited. It has only a minor influence. So the NMDA receptor has only minor influence on white matter. That is why that issue we see, right? And we see what is the difference in between cerebral blood volume in gray matter 4 ml versus cerebral blood volume 2 ml in white matter, and flow is also quite different. Another question: what is not true about the role of microglia in the ischemic cascade? So first option is that they are final cells to be recruited at the ischemic site. They remove synapses stacked by complement systems. They produce BDNF, which promotes neural growth and healing. And fourth is they produce IGF-1 that enhances axonal growth. What is not true about this? Right. Start voting now. What is not true about role of microglia in ischemic cascade? Time up. Let's see. So 42% got it right that this is wrong, you know. In fact, microglia cells, they are the policemen. So they are right there and they're the first one to respond to the ischemic insult. Next question. Now these are pretty simple day-to-day questions. So what is the maximum window in which we can recanalize a vessel in an ischemic stroke? Is it up to 4.5 hours? Is it up to 18 hours? Is it up to 24 hours? Or it depends on tissue at risk? Right. Start voting now. What is the maximum window in which we can recanalize a vessel in ischemic stroke? Great. Let's see the results. So many of us go by the book and we say that it is up to 24 hours, but this is the right answer, that it is still variable, and tissue at risk, this concept is more important now than time window, and all the trials are being done in that manner to escape the time window and look at the tissue. So penumbra imaging identifies the tissue at risk, and Dawn trial showed that even if there is a good penumbra, we should recognize even up to 24 hours and even beyond. Right. Next question. This is also a reasonably simple question. So best NOAC for elderly with AFib and mild CKD. Is it rivaroxaban 10 milligram OD? Is it apixaban 2.5 milligram BD? Is it dabigatran 110 milligram BD or edaxoban 60 milligrams BD? Let's start voting here. Get ready. And your time starts now. Best NOAC for elderly with AFib and mild CKD. Which one is this? I would say this is a rather simple quiz question. Let's see the results. This is the right option, and absolutely nearly half of us got it right. And apixaban is the most renal friendly NOAC due to its less dependence on renal clearance, and it undergoes mainly GI clearance, and bleed risk also is less. Right. Now, what is the recommended duration of antiplatelets for TIA or minor stroke? Is it 90 days? Is it 60 days? Is it 3 weeks? Is it 6 months? This also should be an easy question. Let's see how many of us get it right. Great. Oops, sorry. I think there was a goof up. So I'll give you the, yes, give it again. Please vote. Great. Let's see the results. So since most of us feel that it's 90 days, I think it's 3 weeks now. Let's see that the CHANCE trial is the only trial that showed good benefit for dual antiplatelet in short term, that is 3 weeks. So we should be giving for 3 weeks and then go to single antiplatelet. Well, now the next question is, what is the upper limit of blood pressure in post IV thrombolysis period? Is it 150 by 90? Is it 180 by 110? Is it 180 by 105? Or is it 210 by 110? Let's get voting. What is the upper limit of blood pressure in post IV thrombolysis period? 150 by 90, 180, 110, 180, 105, or 210, 110. Great. So yeah, actually there is a revision here. That's why this confusion. So the revision is that the recent guidelines mention is at 185, 105. I think this is 180 and not 185. Yeah. Right. Now, regarding the subarachnoid hemorrhage that we just listened, the Ottawa subarachnoid hemorrhage rule includes all the following except age less than 40 years, neck pain or stiffness, limited neck flexion on examination, and witness loss of consciousness. Which one is not a part of this Ottawa subarachnoid hemorrhage rule? Start voting now. Ottawa subarachnoid hemorrhage rule does not include which of the following? Let's see what's the result like. Great, wonderful. So the audience, half of them, have been right. Yes. So for non-traumatic SAH, this Ottawa thing, it's very interesting to see that the sensitivity is 100%, but specificity is only 50%. That means this rule should be used to rule out SAH rather than rule it in. So it should not be used to diagnose SAH. Whenever you are in doubt and you want to rule out an SAH, you should use this Ottawa rule. Now, what are the rebleeding, SAH rebleeding predictors except? So which one is not a rebleeding predictor here? Presence of intracerebral or intraventricular blood, high systolic blood pressure, presence of vasospasm, or acute hydrocephalus. Get ready to vote. Which one which one is excluded out of this? Let's see the results. So presence of vasospasm is the one which is not a part of the predictor. In fact, vasospasm is a complication and hardly ever a predictor. Right. Now let's get to the cases. Some very, very simple, straightforward cases. 59 years old lady, hypertension, atrial fibrillation, weakness mainly of the right side of face and arm, eyes deviated to left, able to follow commands. So mainly Broca's aphasia. What is the location of the vascular occlusion? Is it going to be the trunk of the MCA? Is it the lenticulostriate branches? Is it the superior division or is it the inferior division? Let's vote now. It's going to be very, very simple. Vote now. Trunk, that means before the bifurcation, lenticulostriate branches, superior division, inferior division. This is going to be easy. Great, perfect. So most of us got it right. Clinical neurologists. Great. So the inferior division will cause usually Wernicke's aphasia. Trunk will cause a global aphasia, and lenticulostriate branches don't cause cortical findings. So that's how it is. Now, this is also a rather simple question. Regarding aspect score, which one of the following is correct? First one is that IVT is recommended below a score of 4. 3 axial cuts are required to calculate the score. The maximum score is 42, or score of 7 or less is associated with increased dependence and death. Let's see. Let's look at the voting pads now. Great. Go ahead with your voting. What is correct about aspects? 3 of them are wrong. Yes. So time up. Let's see the voting. Great. So almost 55%, half of us got it right, that the score of 7 or less is associated with increased dependence and death. So aspects, this is there, and there are only 2 axial cuts which are required, and it correlates inversely with the severity, and low score should not be treated with IVT. So low score is a bad score here. Next question is, I'll just shift this thing here. 29 years old female. She smokes. She's on OCPs and has a history of APLA. She has developed right hemiparesis and thereafter she became comatose. What is the most likely diagnosis? Is it going to be a hypertensive hemorrhage? Is it a PCA infarct with hemorrhagic transformation? Is it a myeloid angiopathy with hemorrhage? Or is it a venous infarct with hemorrhage? I want to see 100% voting. Right. 100% should be right here. Go ahead. Start voting now. It should take, yeah, a few seconds more. Oh wow, this is the best one. Like a gift. Yeah. So left transverse sinus thrombosis related hemorrhagic infarct. Now the next question is 49 years old female, right hemiplegia progressing to quadriplegia in 2 hours, very fast, and she's awake, unable to vocalize. She has horizontal gaze palsy. Which one is the most likely cause? Is it bilateral thalamic infarcts? Is it lateral medullary? Is it top of the basilar occlusion, or infarct affecting the base of the pons bilaterally? This is going to be rather simple. Yes. Let's see. Start voting now. She's conscious. That is the hint. What is the most likely cause? Time up. Let's see the results. Oh wow. It's all divided house. Right. So she is basically locked in like state mid basilar occlusion, bilateral infarcts in pons, but only horizontal gaze palsy. Vertical gaze was okay. That's the hint. Is that it's in the pons. Right. So 34 years old male. Now this 100% should get it right. 34 years old male with vertigo, neck pain after neck massage. Mild left ptosis, Horner's left-sided ataxia. Which is the best diagnostic test? Is it carotid ultrasound? Is it transcranial Doppler, TOF, MR angio, or it's going to be cerebral angiogram? What is the best diagnostic test? So start voting now for this condition that we all know. Time up. Time to see the results. Wow. I thought it will be over 90%, but it's okay. Yeah, good. So, we know that it's a left vertebral artery dissection causing lateral medullary syndrome. And if it is a non-occlusive dissection, sometimes MRI with fat separation techniques may be also be helpful, but the gold standard is the catheter angiogram. Great.
Dr. Oza?
Yes. Are we done with the time?
No. I just wanted to ask on this.
Yes.
With the vessel wall imaging,
Yes.
Do we still need to go for the DSA, or for the vertebral dissections, is it possible that it comes to the same, the sensitivity as DSA?
So we published a paper on this in the Journal Stroke Medicine. We showed that if you tweak the techniques like the GRE, you have that double track sign, So
Yes.
there are various techniques, but gold standard remains gold standard. When in doubt, you must adhere to the gold standard. So there, if the story is very very clear cut, there are many ways of doing it, but sometimes you are in doubt, and then you want to do the gold standard. So the question was, which is the best diagnostic test?
Okay, so still DSA.
Yeah, absolutely, yes.
Okay.
Then 59 years old female, she presents with altered mental status, and this is her MRI. We know this MRI. Everyone knows. What is the most likely diagnosis? Is it a bilateral anterior choroidal artery stroke? Is it occlusion of Hubner's recurrent artery? Is it occlusion of artery of Percheron? Or is it a superior sagittal sinus thrombosis? Superior, not inferior. Yes. Let's see. Start voting now. What is the most likely diagnosis of this? This so 100% should get it. This is just, I would say, to tease people. Right. So I want to meet that 27%. Who are they? Right. So very often there is a single artery which supplies both the sides bilateral medial thalamus. It arises from one of the sides of PCA-P1, and this is the artery of Percheron, so it can cause this kind of stroke, obviously. Right.
Again, Dr. Oza,
Yes.
now the fourth choice you gave here was sagittal. But if
Yeah.
it was to be deep vein thrombosis, would that also be a correct answer?
Well, I would, yeah, this is a valid option because we didn't give that valid option. Usually that would have, it will put us to doubt sometimes, but you can see that on the GRE sequences, you can see that vein which is thrombosed.
Okay,
Yeah.
yeah, agreed.
And sometimes it is hemorrhagic, so it's not that difficult most of the times.
Yes.
Right. Now, these are some images that I want to see you to see. And 49 years old male presents with ataxia, and this is the CT scan. Which is the artery which is most likely to be involved? Is it ICA, SCA, PICA, PCA, vertebral? Even I think this is also going to be cakewalk for our guys. And let us see. Start quoting now. So ICA, SCA, PICA, PCA, and vertebral artery. Let's see. This is 11 people voted, and this is the SCA, obviously, superior cerebellar artery, because it supplies the superior cerebellum, vermis, superior cerebellar peduncle, and upper lateral pons. Right. Now, what about the anterior coronal artery? Anterior coronal artery supplies all of the following except: is it going to be anterior limb of internal capsule, lateral thalamus, optic tract, or hippocampus and amygdala? This is also easy question. Start voting. Anterior choroidal artery supplies all the following except. Right. So we got only 20% of us got it right, but this is a teaching point that anterior coronal artery, it originates from the posterior wall of internal carotid and supplies the posterior limb of internal capsule choroid plexus. Right. We know the triad of hemiplegia, hemianesthesia, and hemianopia. Right. Now, what about the recurrent artery of Hubner's? It supplies all except tail of caudate nucleus, medial portion of globus pallidus, anterior crus of internal capsule, and anterior hypothalamus. Which one it does not supply? Start voting now. Recurrent artery of Hubner. Great. So it's a completely divided house, and only 30% of us get it right. So the recurrent artery of Hubner supplies the head of caudate, and tail is supplied by the anterior coronal artery. And the clinical manifestations are: if it is unilateral, it causes weakness of the contralateral arm and face, dysarthria, sometimes hemichoria. Bilateral, it causes a kinetic nude state. Right. ICA supplies all except MCP, inferolateral part of pons, vermis, and cranial nerves. ICA, yeah, this one is going to be interesting. Let us see. ICA supply, which supplies all except. Great. Now let us see the results. This also looks like a slightly divided house, and 50% of us got it. 56% of us got it right. So the superior vermis is supplied by SCA, and inferior vermis is supplied by PICA. So ICA doesn't supply the vermis. Right. Now, I think there are last two questions that we are going through. So, which trial showed benefit of mechanical thrombectomy after 6 hours using clinical imaging mismatch? Was it diffuse 3? Was it dawn? Was it Hermes? Was it pre-flare? So get ready, guys, to start vote. Start voting now. After 6 hours using clinical imaging mismatch. Time up. So 36% got it right. So I think we are jacked here, and we have the results already. So here we have a winner who got 18 right out of 27. Actually, there are three, but there is a like a fastest finger first kind of thing. And Gitin, Binoy, then Saurabh Jain, and Adwaita. They are, I think, the top three. Right. So I'll stop sharing my screen here. Yeah. Thank you, Shripad. I'm here back again. Hand over to you.
Great. Couple of questions
Yes.
on the related to the quiz. One is the apixaban.
Yes.
We chose, yes,
Yes.
amongst all of them, right. But when we say mild renal impairment, do we mean the creatinine clearance between 30 to 50? Is that what it means?
No, so the issue is that in the apixaban trials, creatinine clearance was not taken. It was the only creatinine. So that is one more advantage that we just do creatinine and decide on that. Yeah.
Okay, so because for dabigatran and rivaroxaban, as I
Absolutely. Yeah.
this I always check the create clearance before
Yes.
I decide whether to give or choose the dose.
Absolutely. So the only
Not so
advantage
with
that I see here is that
apixaban.
it's create. Yes.
And I remember in the last lecture by Dr. Vineet Banga on aspects,
Yes.
when he said two cuts for aspects, it means the CT aspect, correct?
CT aspect. Yes.
Yeah, the CT aspect has no involvement for vertebrobasilar artery territory.
No, no. It is all MCA. Yes.
It does not take into consideration
Perfect.
this
Yes.
thing. Whereas if you use MR aspects, then you can do anterior circulation as well as posterior circulation.
Yeah,
Correct?
but but that is not standardized. It is called as a PC aspect. That is posterior circulation aspect. In
Yes.
fact, Dar Daloche, from Calgary program, he had done for this also. If I'm right, he had done for posterior circulation aspect. That is also published. So,
Yes.
but it's not a very as nice as the anterior circulation.
So as of today,
Yes.
if we have the diffusion with us, shall we use the PC aspects as a modality to decide or not?
I would say that you can use, but it is not well standardized. That is
Okay.
my take on it. So, but
Okay.
obviously we need to describe something more in detail. Yeah, but it may not be a statistically valid option.
But in exceptions. Okay. Okay. Good. I think a very nice quiz we had. It had
Thank you.
everything right from basic science to clinical to investigations to treatment. Very nice. I think I hope our PGs realize the vast spectrum of scope.
Yeah.
Bansal
I'll
and
just I'll just make a comment to Saurabh.
yes,
Yes, sir.
Saurabh, I liked your presentation quite a bit.
yes, very
Yeah,
nice.
yeah, absolutely. I mean, you did a fantastic job.
Yes,
And the even the SH presentation was like, I would say we should have given at least 45 minutes to SH only.
yes,
True,
yes,
sir.
yes,
That
True,
was
sir.
it
yes.
was so
True.
nice, Yeah.
Yeah, it is difficult for the speakers to cover things in around 20 minutes, but unfortunately they are asked as a short note. So all the fine committee sort of requests everybody, urges everybody to, cut it down to 20, less than 20
True,
slides.
sir. True,
And I
sir.
have one question to Dr. Shripad also.
Yes.
See, when you take quiz, how do you hand over those chocolates now? I mean, to the winners. Is it like going to be
That,
e-chocolate or how is it?
no, no, no. There has been a plan, Dr. Kothari Gulsen, and I have been
Yes.
talking about this. We will come together for this and decide something, maybe a voucher or something. Yes, yes.
API had given Swiggy home delivery.
Yeah, I think a late
That's a
supper,
great
I
idea.
suppose. A late supper. Yes, after an exhaustive quiz. Great, great. So anybody wants to add anything to help PGs train themselves? And this really the most important thing, I think. So anybody want to say? Yes,
I think it's going great. I think all the coordinated effort, will help
absolutely.
them. Yes.
Yes,
True.
absolutely.
Absolutely.
And all the lectures will be shared as PDF, so don't worry about this. It may take a few days for me to upload, but they'll be shared. Thank you, Balkrishnan.
Great.
Thank you, Bansal.
Thank you,
Thank you,
sir.
Dr.
Thank you.
Oza.
Bye.
Thank you.
Bye.
Enjoyed
Bye.
the
Bye.
session. Really
Bye.
enjoyed it. Great, great.
Bye.
Thank you.